Hello and welcome to this episode of the Optometric Insights show, where I'm joined with Dr. Nate Lighthizer, and we're going to be talking about OCTA and the diabetic patient. Dr. Nate Lighthizer, thank you for being a guest on our podcast again, and welcome again to the podcast. Please give everybody a little bit of a background of yourself, just so people are kind of familiar with your background.
Thanks, Mile. Appreciate the invitation. Glad to be here. Nate Lighthizer, faculty member and the dean of the NSU Oklahoma College of Optometry in Tahlequah, Oklahoma. I've served in a variety of roles. I'm a clinician. I teach a couple of classes, but pride myself on being a clinician. I was in patient care this morning, in whether it's dry eye clinic, laser clinic, lump and bump clinic, diabetic clinic. We have four of those every week. So we see a variety of ocular disease patients, and our faculty are true experts in teaching ocular disease and managing these patients. So looking
That's
forward to
great.
talking on OCTA and diabetes.
Yeah, well, I know, Nate, that you are certainly a leader in the profession, and with what you've done to help promote laser and increased treatment for optometrists across country is absolutely fantastic. But today we're going to be talking about, as you said, OCTA and its role in diabetic patients. So, Nate, just give us a broad overview on why we would even need something like this in our diabetic patients and why OCT angiography makes sense in diabetic patients.
I think we've been, especially myself, we've been guilty for too long on kind of just doing things the way we've done them for a long time. You think of the most common, ancillary tests that we run in our diabetic patients and diabetic retinopathy. We look, obviously, we do DFEs, we
Hmm.
take fundus photos, we've been doing OCT, and that's all great. But we can now look at things in different ways. I always encourage docs, look at functional testing like ERGs or color vision,
Yeah.
but an OCT angiography tells us something that we can't see with the naked eye on our DFE, on our fundus photos, or our regular OCT, to be able to see that vasculature, to be able to look for capillary dropout, to look at the foveolae vascular zone. There's literature out there that says you can now see things on OCT angiography that help us to diagnose diabetic retinopathy sooner. And Mila, you know very well that the sooner that we can diagnose something, the sooner we start educating patients on this is what we have, this is what we're seeing. Patients, they can struggle with non-compliance, but the more info we give them, the more testing that we give them. I tell them an angiography here, if you have a poor angiography of the heart, that's going to catch your attention. You got a poor angiography of the retina, that concerns me. That's going to catch our attention. So I just think this is something that gives us more information in a different way. It doesn't replace OCT doesn't replace fundus photos. It pairs with them beautifully. Knowledge is power, and the more information and more knowledge we have, the better care that we give to our patients.
I think it helps us understand things a little bit more too, Nate. There are situations where there's the absence of visible diabetic retinopathy when we see them in a traditional sense. Standard fundus images, standard fundus examination. We're actually part of a large clinical trial right now where we're doing the eye exams for individuals in the trial that are being treated with the diabetic medication. And one of the metrics they want is macular OCTs for obvious reasons. So, Nate, you do have a few cases that you wanted to talk about here, really highlighting this, because again, I think what we're really thinking about when we think about the diabetic patient is vascular compromise, what that might look like in an OCTA, and what do we do with the information? So share with us the nuances around that, and then why don't you jump into the cases that you have for us too, Nate?
Yeah. So when we look at this in our diabetics, again, we scan this in all of our diabetics now, and just to make sure we have a proper understand, like you said so well, a better understanding of what's going on at the retinal level. We will get an OCT angiography of the macula. We'll look at and measure the foveolae vascular zone. We'll look at the capillary networks, whether it's the superficial capillary plexus, the deep capillary plexus.
Nate, if you see an enlarged foveolae vascular zone or if you see capillary dropout, is that something that you're communicating to the physicians that you're managing these patients with, even in the absence of traditional diabetic retinopathy?
We are, and Mile, I may be going against the way it's traditionally graded, but I now believe clinically as a clinician, if I'm seeing an enlargement of the foveolae vascular zone or capillary dropout, even in the absence of traditional retinopathy, I now believe that that patient has retinopathy. Maybe not
Yeah.
be able to find it with MAs and things like that, but that's how I believe they have retinopathy going on, and for that reason, we communicate with their PCP. Yes.
I think in the next decade, we're probably going to have a restructuring of what we traditionally thought was diabetic retinopathy categories. And in addition to what we see with fundus examination, there's also going to be these supplementary tests that are going to give us greater understanding of how we grade retinopathy because of the insights that you're actually seeing, Nate. How many I love your systemic examples. If you knew your kidney, the blood vessels in your kidneys were 50% reduced, would you feel good about that? Would you want to continue with the path that you were on? No, there would be some type of intervention. And I think we're getting to a point with diabetic patients with that as well, to understand that vascular supply.
Yeah, they get that more. That's why I use the EKG analogy for ERG, and
I
I use
love that.
angiography for OCT angiography because
I love
patients
that.
understand that and it matters to them. And if I can connect with them at another level so they're a little bit more compliant, work on their
I
A1C
love it.
better, maybe take that nutritional supplement, that all contributes to better care because Mila, it's partly my responsibility, but it also lies on the patient as well. And we need to communicate as best we can and give them a proper understanding as well as us. So I think that's all ties together.
So, Nate, share with us one or two examples of patients and angiography scans and how it's provided you greater insights into the overall health of that individual that are diabetic patients.
Yeah, yeah, I'll never forget. I had a couple of patients on the same day in diabetic clinic, and one was actually she wasn't even diabetic yet. She was a pre-diabetic. She was in her, I think she was in her 40s, and she was pre-diabetic. She had some systemic symptoms, a strong family history. She was unhappy with her vision, so we were doing an exam on her, and she
Hmm.
had no retinopathy, no traditional retinopathy, but yet her capillary network was reduced. It was concerning to me. Her ERG was reduced as well. So this ancillary testing, concerned me. And ultimately with our job, Mealy and retina, we're not sticking the needle in the back of the eye. We're not lasering the retina. But what's our job in retina? Risk assessment. How likely is this patient going to stay stable? How likely is this patient going to go south in the next year, 2 years, 3 years? How closely am I going to follow this patient? How closely am I going to communicate with their PCP? Am I going to recommend nutritional supplementation? Well, this diabetic, if you'd have just looked at the back of her eye or pre-diabetic, you'd have said, I'll see you back in a year. But because of the OCTA, because of the ERG, because of the family history, because of the systemic symptoms, I sent her for new testing, lab testing, and her A1C came back 8.4. So she was not a pre-diabetic. She was a diabetic now. And I always tell the docs when I lecture on this case live, here were the OCTs, which looked perfect. Here was the back of the eye, which looked perfect. When would you have seen this patient back? And they all say, I'd have seen him back in a year. And I say, yep. But with the OCTA, I think we need to follow this patient more closely. They are starting already down a road of diabetic retinopathy that we don't want, and we need to follow them more closely, educate them better, maybe recommend a nutritional supplement in this newly diagnosed diabetic. Contrasting that, the next patient was a 16-year diabetic. Mile, generally speaking, which diabetic are you more concerned about? The 25-year diabetic or the 2-year diabetic? Generally speaking, it's the 25-year
Longer.
diabetic.
Sure.
Well, so I'm like, okay, newly diagnosed diabetic or the
Yep.
now 16-year diabetic, which is my next patient, which one would you be generally more concerned about? The 16-year diabetic. This patient's 20/20, just like the last patient, and their back of the eye looked just fine, but their OCT angiography showed a beautiful capillary network. I mean, it was robust, it was thick, it was just as you would expect it to be. And guess what? The ERG matched, but the fundus photos looked exactly the same. This pre-diabetic, now diabetic, and then 16-year diabetic. You couldn't tell a difference between the fundus photos. The OCTs looked exactly the same. It was really the OCT angiography where you could see that capillary network. It looked much better in the 16-year diabetic. And I said, I'll see you back in a year. You're doing great, Mr. Jones versus Mrs. Jones, the previous one. We need to follow that patient more closely. So I think this ancillary testing, pairing OCTA with OCT and ERG and fundus gives us better care overall for the patient. So that really stuck out in my mind in those two consecutive cases. The newly diagnosed had a worse capillary network than the 16-year diabetic.
It's great. So, Nate, do you find any differences with the amount that you've done now with OCT and geography? Are you finding any differences in visual function and also acuity levels in those individuals that have larger foveolae vascular zones or more significant vascular dropout? Or is it not really correlating with what you would expect with reduced vascular dropout or with
So
increased vascular dropout, excuse me?
what I have seen a strong correlation between the OCT angiograms, the findings that I get in the macula, and their
Hmm.
ERGs. If they have significant vascular compromise, their ERGs are pretty abnormal. If they have strong vascular, their vascular looks great, their ERG usually looks pretty good. It looks very
Good.
good as well. So strong correlation. Visual acuity, although it can be tied, they've got to lose a lot of capillary network before
Yeah.
visual acuity starts to fall. So, I wouldn't rely on visual acuity to help you determine how's that diabetic doing. So it's not quite as strong a correlation. Can it be tied? Certainly. The more that the foveolae vascular zone gets bigger and bigger, yes, but it's going to have to really drop out before
Yeah.
they start to lose significant acuity in my clinical experience. Maybe yours is different.
Well, now, Nate, visual acuity is a very, very difficult thing to shift. Visual functionality, though, is the interesting one because it's difficult to assess clinically unless you have some type of objective marker like you were talking about with the ERGs. But, it's other than that, and potentially even MPOT, it's more or less hey, how are you functioning at night with your night driving? There's so many other things that can be influencing night driving, influencing your changing from going from light to dark. But you do tend to see these individuals just be, I don't want to say lethargic, but they do function differently than those individuals who have this robust capillary plexus where they're not showing dropout. Nate, this was awesome, buddy. I really want to thank you for being here and taking time out to be with us today. It's always a pleasure to pick your brain a little bit. You're so genuinely astute when it comes to understanding the science behind the things that we're doing and also how it applies clinically. And that's one of the things I always appreciate about you, Nate. Thank you. Thank you for being on today.
Glad to be here. Thanks, Mile.
And thank you all for joining us on this episode of the Optometric Insights Show.